Good afternoon. So I imagine that a few people will keep trickling in. Um, I'm David Mayer. I'm a faculty member in family and community medicine um, and a member of the local Physicians for a National Health Plan um, chapter. I wanted to briefly just make a couple of very quick announcements out if you become interested or have already have interest in this area. We have email sign-out sheets out in the foyer. And there's also a local event that I wanted to tell you about. And this isn't very good. I didn't write down the date. It's October 9th. So it's October 9th. It's a movie called Fix It, Healthcare at the Tipping Point, which talks about the problems of the healthcare system from the point of view of of business owners who are trying to insure their employees. Those of you who read the New York Times will note that there's an article about this topic also that just appeared. And that will be at 6:30 at the library. And Jan Swaney here can give you more information. So with those two brief announcements, I wanted to introduce our speaker. We're really privileged today to have Claudia Fagan with us, who is a national coordinator of the Physicians for a National Health Plan. She's an internal medicine physician who did her undergraduate work at Fisk and got her MD degree from the University of Illinois College of Medicine. And her day job is currently as executive medical officer for Cook County Health and Hospital Systems, as well as some other things, but I think I should stop and let her do the talking.
Thank you. I'm really happy to be here. I'm glad I see a fair number of medical students because we're going to be talking about the environment in which you'll be working, and that should always be important to people. I have no financial disclosures. I'm a government employee, and I don't take income from anyone else. And I'm going to talk about an issue that faces every country. I would say that every country has its own personality, right? No matter where you are in the world, each country assumes a little bit different personality. But one problem that everyone looks at is how do we take care of the people who live here? How do we provide for our population? And so I will say that the United States is the only industrialized country that does not guarantee access to health care. But I'd like to spend a moment talking about the way in which other countries have addressed this issue. So some of the common finance models that exist, one that many people are familiar with is the National Health Service. So this is where we're talking about public funding and public delivery. The government owns pays for the health care that is delivered, and the delivery is by employees of the government. The hospitals are also owned by the government. And this is a model that exists in the United Kingdom, exists in New Zealand, exists in Italy, exists in Cuba, numerous places around the world. The next one is national health insurance, and this is where you have public funding, but you have private delivery. This is the model, or as we are talking about, an improved Medicare for all. The model exists in Spain, in Ireland, in Canada, Australia, and Sweden. And then there's the Bismarck model, and this is modeled after Premier Otto von Bismarck, who was the Prime Minister of Germany following World War I. And they developed what are called sickness funds. Many people say these sickness funds are most closely resemble what we have in this country in terms of insurance companies. It has mixed funding with private delivery, but it is highly regulated. So although we think that these sickness funds may resemble insurance companies, there are a couple of rules that are kind of make them different. So the sickness funds may be sickness funds for artisans, or it may be artisans rather, and it may be artisans, or it may be for agricultural workers, and you are usually born into a particular sickness fund, and you probably stay with that fund your entire life. They must offer the same benefits, and they can't make a profit. So they compete on service. They compete on, one fund may offer gym membership, or may offer access to particular classes that people are interested in. They cannot turn anyone down. They cannot deny anyone care. And if one fund gets in trouble, maybe they have a few really sick members, need a couple of transplants, and the fund is underwater in terms of financing, then another fund that has done better will have to supplement the fund so that they all still survive. I just haven't figured out how you get Cigna to write that check for Humana, you know? But people say that, you know, we could expand the regulations of the ACA, and that might be what that would look like. And then there's this multi-payer, which is mixed funding, mixed delivery, which is, we're unique in the United States because we're the only one who seems to do it this way. I would say that the important observation to make here is that everybody else manages to cover just about everybody, 99.9% of the people who live within their borders. Did you hear what I said? I said people who live within their borders, because I didn't say citizens. And so we managed to cover about 85%. And I would tell you, working at Cook County, in my view of the world, there are like 4 major ways in which people have access to care or not in the United States. So I would say the first delivery system is people who are working who are under the age of 65. So they have, that's similar to the sickness funds, where the employees and the employers both contribute and pay for the premium. The average employer in this country pays 87% of the premium. Employees pay about 13%. But there are some companies that kind of broke the model on that. You know, Walmart typically makes their employees pay much more. There are some companies that make let their employees pay much less. Some employers pay all of it. I will say, as of yesterday, we hit a new high. The average premium for insuring a family for a year is over $20,000 in the United States now. Most people pay about $6,000 as their contribution for the premium. So it's a joint venture, not an even, but a joint venture between employees and employers. And one of the things we're going to talk about is what's happened to these policies and what they look like as a result of the increasing costs. So then there's what people over 65 have in this country. People over 65 is similar to Canada or Sweden, where we have Medicare. And I will tell you that Lyndon Johnson borrowed the term Medicare for Canada. They had it first. It started in the small province of Saskatchewan in about 1961, and they fully implemented it in 1971. We'll come back to that. But it is the notion that it's again a partnership between the federal government and people over 65, where the federal government agrees to pay 80% of the cost, and the person over 65 pays 20% of the cost, or they purchase a supplemental. This goes back to a mindset that exists in our country. It's been proven wrong, but it's a mindset that we haven't changed on, that we believe people have to have a financial stake, or they have to pay something for their health care, 1, to value it, and 2, to use it appropriately. I'll talk about why no one believes that's right anymore, or people who do believe it right haven't read the studies and don't really understand. And then Native Americans, veterans, and members of the military, it's similar to the National Health Service Corps in National Health Service in Britain or Cuba. As I said, government-owned buildings, government employees who provide the care. And then the fourth way, I would say to you, is similar to Cambodia or rural India. So we don't provide any guarantees. You get what you can or not. So I would tell you that we already spend enough money on health care in the United States, and this is going to be a recurring theme, is that we let too many people who are not involved in the delivery of care take profit from it, and I'll explain that. But I will say that I think there's going to be a problem because there's battery is flashing that there's no battery left in this device. But you can see the white bar, and you can see that at $6,500 in public dollars, we already spend more than most countries do on health care. And then if you add in what we spend in private insurance premiums, we are over $10,000 per capita per year. We spend $10,000 per person living in the United States per year on health care. And yet we leave a third of the country either uninsured or underinsured. And we'll talk more about what I mean when I say underinsured. So here's what I wanted to show you. This is the gross domestic product of the United States. In other words, we are an economic engine, as a country. And so the red line is a graph of what percentage of our gross domestic product do we spend on health care in the United States. And you can see that we are quickly kind of zooming up there toward 20% of the gross domestic product, which is a huge amount of money. So in 1973, we thought, we are really on the wrong path and we're spending too much. So we enacted the Hmo Act because we decided as a country, we said we're spending too much on health care. We need to do something dramatic to curtail health care costs. And we believed that fee-for-service was the problem. That the more doctors did, the more patients they saw, the more procedures they did, the more they got paid. And that was an inflationary way of compensating them. And what we should do is we should capitate them and say, we'll pay you so much per member per month. And you're going to get paid that regardless of the work you do. And that's called shifting the risk. Because now, if you're taking care of a patient who requires a lot of care, you're still getting paid the same amount. But if you're taking care of a patient who never comes in, you still get paid the same amount. So that creates an incentive to not see so many people because you could make this money whether you see the patient or not. And so that was going to control cost. And you can see that it didn't make a big impact on the direction of the graph. The Canadians, on the other hand, were in a similar spot. They were spending an increasing amount of their gross domestic product on health care. And so they said, we need to do something different. And their decision was, we're going to pay for everyone. And that this would be a partnership between the federal and the provincial government and the additional 3 territories. And that the federal government would pay so much and the territories would pay so much, but between the two, they would cover all the cost of all medical care, medically indicated care. Who decides what's medically indicated? The specialists, the physicians, the specialty societies, and the government agree, okay, the people who deliver the care know what care is indicated, they'll decide. Simple. So the Canada Health Act was first, had its beginnings in Saskatchewan under the guidance of Tommy Douglas. There's a U.S. connection there because Tommy Douglas's daughter was Shirley Douglas, a famous actress, and she married a guy by the name of Donald Sutherland, and they had a son named Kiefer. Okay, just a little aside. So I met Madam Douglas earlier in my career. We had a great conversation about the difference of health care between the two places. She was born, by the way, in the living room of her family home because the doctors were on strike because they didn't want to have Medicare. But then after it was enacted and the doctors in Saskatchewan, their incomes immediately skyrocketed because they suddenly got paid for everyone they saw and they got paid real money instead of chickens or corn. Then all the other provinces said, hey, that sounds like a good idea, and the rest is history. But so they were fully enacted by 1971. And unlike our great idea about managed care, they actually made an impact on the curve in terms of their expenditures. So how much is the administrative cost associated with this plan? The administrative cost in Canada for covering everyone, regardless, and the person just comes in and says, I'm Claudia Fagan. Doc says, okay, fine. And at the end of the month, the doc sends in a piece of paper, I saw Claudia, and here's your payment. That was agreed on by a specialty society. So the administrative cost is $863 per capita per year. That's what they pay. Sound like a lot? We pay $3,300 $3,300 a year. So some people would say that that's kind of a hidden tax that we pay. That's the additional administrative costs we pay for the administration of our wonderful system, which leaves 15% of people out completely. So what I would say to you is that the Canadians did it one way, we did it a different way. They spend half as much as we do, and they have fewer unmet health needs, and they live longer than us, because we like to say we have the best health care in the world. We do. We say it everywhere. We have the best health care in the world. I'm a public health doc, and I'm going to ask you, by what measure? So our life expectancy is less. Our infant mortality rates are higher. And this is the one that really galls me. When I finished my training, the number of maternal deaths, not infant deaths, maternal deaths per live birth was less than 10 per 100,000 live births. Today that number, anybody know? 26. 26 women die per 100,000 live births in this country in 2019. We know more about pregnancies, we have more technology, and almost 3 times as many people die. So what are we doing? What have we accomplished? I mean, I know we come along. I'm a twin, and my mother didn't know she was having twins till the day we were born. We have figured this out, and yet we cannot save women's lives. Oh, did I go past? All right, so one of the problems that we have with the Affordable Care Act is it leaves in place the worst features of insurance or employment-based insurance. Employers can change coverage and plans, and they do. They make economic decisions and they change plans. The average amount of time that anyone stays in any particular insurance plan in this country today is 18 months. The insurers can change provider network. The insurer doesn't care that your provider, you've been seeing that provider for 20 years, that that's your primary care, your family doctor. That person's address doesn't match, their clinical practice doesn't match, or whatever reason, they don't want to sign the contract, they're no longer in the network. Employees have to accept the plan their employers offer them. They can't just go out and purchase something else. And the plan is for market forces to lower the cost. Has not been proven to work. And I'm going to come back and talk about what we think market forces have done for healthcare in the last 20 years. So one of the reasons that people don't really get very hot and bothered about the ACA is because the majority of people are not affected by it. Over 50% of people were insured by private insurance before the ACA. Over 50% of people are still insured by private insurance after the ACA. They don't have any skin in the game, they don't care. It's not heartless, it's just kind of the way we are. So we have fewer uninsured. That is definitely true. But even when fully implemented, and not even talking about states like Missouri where they failed to expand Medicaid, the plan was always going to be there was still going to be more than 20 million people who were going to be left uninsured. So, you know, you say, well, in a population over 300 million, what's a few million? They're real lives. They're real lives. 28 million left uninsured in the United States. And it's sort of like, okay, I'm so sorry you have that problem over there, but I'm over here and you guys, good luck with that. I always thought that the purpose of insurance was to protect your financial assets, you know, improve access to care, and protect your health, right? You buy insurance so that you can afford to pay your bills. You know, I had a car accident on Friday. It's unfortunate. I was very upset. My pretty little red sports car was. But the insurance company said, it's okay. We got you covered. Don't worry. You've been a good driver, never made a claim. We're going to waive the deductible. We're going to take care of it all. I said, that's what insurance should do. I've been paying all these years. That's what it should do. The majority of bankruptcies in the United States today are still the result of medical illness and medical debt. And those people who go bankrupt as a result of medical illness or medical debt, were insured at the time of the precipitating illness or death. So, what have market forces done for healthcare in the last 20 years? Well, they've increased the number of insured and underinsured. So what do I mean by underinsured? Underinsured means, yeah, you have coverage. You know, I like to describe it as like a hospital gown. Looks pretty good in the front. Everything's hanging out in the back. So it's like this conversation I have with my son. You know, my son was working as an assignment editor in a news station, a TV station, a little station in Elkhart, Indiana, making all of $35,000 a year with his 2 college degrees, and had a deductible of $3,500. So we're having this conversation because he's texting me a picture of his big toe. And he's got an ugly-looking paronychia, and I'm saying, James, you got to go to the emergency room. No. James, you got to go to the emergency room. I see these red streaks on your foot. You got to go to the emergency room. Come on, Mom, can't you just write me a prescription? Can't you just phone something? You know, so we had that fight, and I don't know how long it took him to pay off that bill. But we don't talk about it anymore. He has a better job. He's back in Chicago, and he has real insurance. So it decreased the choice of providers. It's resulted in consolidation of HMOs because you've shifted all that risk, and not everybody, those little folks can't afford to absorb the risk that's associated with managed care. We divert healthcare resources to areas of profit rather than need. What do you mean? What are you talking about? Well, the premium dollar. How much of the premium dollar actually goes to delivering care? Now, I haven't walked around downtown Columbia yet, but I have been in Chicago, New York, San Francisco. I can't name a big Miami. Can you name a big city that doesn't have some towering building, some prominent edifice that is not an insurance company, that doesn't have a John Hancock building or a Prudential building or Transamerica building, or are there Cigna? Is there one? I don't think so. So those were dollars that went from premiums that went to pay CEOs and pay staff, but didn't go to delivering care, didn't buy insulin. So underfunding of less profitable endeavors. What does that mean? Have you tried to get behavioral health services in this country lately? You know, so people have plans that have no psychiatrist in them or offer no behavioral health benefits. People have plans where there are no behavioral health providers within a 100-mile radius. People have plans. There is no parity between medical illness and behavioral health. And yet we're in an epidemic. Suicides are on the rise. We have opioid addiction. And yet insurance doesn't cover the care that's necessary because there's not a lot of profit in that. So we have unaffordable prescription drugs. I alluded to insulin. I'm going to talk about another pain point, colchicine. Colchicine. Colchicine used to be pennies a tablet. For those who don't know, you younger folks who may not have experienced this yet, it's for gout. And I used to be able to tell a patient, you know, you have your attack so frequently, I'm going to write you a prescription, you can take 1 colchicine a day, and you don't have to have gout attacks. So I'm the chief medical officer for Cook County Health. I have a $65 million pharmaceutical budget. I can no longer afford to have patients get daily colchicine. So I had to set a maximum. They can only get 10 tablets. So you wait till you get a gouty attack, and then you take 1 tablet, and if you're still in pain in 2 hours, you can take another. And if you still have pain 2 hours later, if you don't have diarrhea, you can take another. So now we've said to our patients, we're sorry you have gout. We can't prevent you from having an attack, but when you have one, we'll give you something to treat it. Because otherwise, I won't have enough money to buy insulin, which was started at a few dollars a vial, and now it's a couple of $100s a vial. So what market forces have done for us is resulted in dissatisfied patients and physicians. And a lot of them have left practice because of it. And I can tell you that the costs have not gone down. So the biggest flaw of the ACA is that it limits the list of doctors and hospitals. It causes gaps in coverage and benefits. There are financial barriers to care. There's needless complexity, and we still leave millions of people uninsured. So I think Medicare for All offers comprehensive coverage, preventive services, because it's so much cheaper to treat your blood pressure than it is to take care of you after your stroke, hospital care, physician services, dental services, mental health services, medication expenses, reproductive health services, home care, nursing home care, long-term care. I want to remind people that 80% of the Medicaid budget in this country goes to paying for people who are living in nursing homes, and we do terrible things in nursing homes when we could spend a little bit less but provide people with home care and let them stay in the community. And the other problem with that, in terms of warehousing people, we require people to exhaust all their financial assets, to spend themselves down into bankruptcy so they're eligible for the Medicaid to go into the nursing home. It's horrible what we do to elderly people, and we are all going there if we're lucky. So physical and occupational therapy. So all medically necessary services, no co-payments or deductibles. Why? Because the Rand Corporation did an experiment in the 1970s using co-payments of 50 cents or $1. And what did they find? That co-payments, no matter how small, deter people from necessary care just as often as unnecessary care. Because if you ain't got it, you're not going, all right? So while whatever it would have cost my son, I could have written that check for $3,500, but he did not have the money to go to the emergency room, and it took him a very long time to pay off that bill. So the question is, how can we afford all of this? Well, what did I tell you? We're already spending enough on health care. We spend more than anywhere else in the world. So we have 29 peer-reviewed, published studies that show that we have enough money to provide fund full coverage for everyone. There are economists who say, you know, we should get this done. It doesn't make sense. I would say to you that taking care of patients is not the same as making widgets, and that, or making cars, and that the market forces we keep thinking are going to control cost do not apply to health care. We have decided that public education is a public good, and that every child should be educated. And in every city in this country, we provide access to public education. We have decided that the police and fire are safety issues, and that everyone should have access to them. And everywhere, we provide that. We have not yet decided as a country that health care is a public good, that making sure that everyone is healthy is good for the entire community. You know, it's like we're sitting on the other end of the boat. I have mine. You know, that's too bad about what you got going on over there. That doesn't apply to us. What I will say to you is that the savings from going to an improved Medicare for all would allow us to cover everyone. We've crunched the numbers many times. It always comes out the same. The GAO has published on this at least 3 times. You get improved quality with single payer, because with a single tiered system, everyone has a vested interest in the quality of care that is delivered. I can't tell you how important that is. I got a report card from Aetna some years ago before I left private practice for heart failure. I had a panel of 2,000 patients. Most of them were not Aetna patients. And it turned out, I got a really high score, higher than any of the cardiologists I knew. It turned out I only had 3 patients with a diagnosis of congestive heart failure who had Aetna coverage, and none of them were hospitalized that year, so I looked like a star. But they could not look at the breadth of my practice. Single payer allows us to look at the breadth of the practice and allows us to say, Dr. Fagan, you know, maybe you're not treating community-acquired pneumonia the best way. Let us help you with that. let's see if we can send you to a course and have you look at things a little differently. It's not about eliminating doctors or kicking them out of practice. It's about helping them. It's about identifying problems and looking for solutions. The system would provide continuity of care. In France, your health card is embedded with a chip with your medical record. So when you go in, you give them the card, they can see what your immunizations are, they can see when you had your last tetanus shot, they can see whether or not you've had a flu shot, they can tell what operation you had before when you couldn't remember what that was. And then whatever treatment they do, they add it so that when you leave, the next place you go will have a record of what you have and what the problems are. I know that I'm in Missouri and Kansas City, where I was last night, is the home of Cerner, and Wisconsin is the home of Epic. In Chicago, we use Cerner, and 3 other major systems in the city use Cerner, but they're all different versions. They don't even talk to each other. So I know we have the health information exchange. It's not working so great, but we need to get there. Preventive care has to be a priority. Oh, I did the wrong thing there. What did I do? Okay. Got to look at this thing. All right, so we have to make a unified, useful electronic health record. Facilities have to be real planning. My question is, how many MRIs do we need? How many places do we need doing cardiac surgery? The American College of Cardiothoracic Surgeons say that a team, the pump specialist, the anesthesiologist, the cardiac surgeon, all of those folks need to be a team and work together. The team that does less than 270 procedures a year has higher morbidity and mortality. We've done really good with heart disease in this country through use of statins, through the use of controlling blood pressure. And so the majority of places doing cardiac surgery today are doing less than 270 procedures a year. Now, places that do over 350, they hum. And the question is, everybody wants to do cardiothoracic surgery because the reimbursement is really good. But that doesn't mean everybody should. It's what I say to my residents, just because we can doesn't mean we should. So Medicare means healthy Americans. And so how do I know that? So look at where we rank in terms of health care before the age of 65. And look what happens when we turn 65. This is not new. In 1965, when we implemented Medicare, we watched the disparity for Black Americans with health care access to Medicare. We watched the disparities between Black and white disappear over the age of 65. And now we see it on a global scale. What happens at 65? Suddenly people have access. Patient cost sharing blocks access to care. It reduces adherence to medications. The RAND Corporation did another experiment in the early aughts where they looked at what the impact of co-payments on how people took their medications. And it was very systematic and very reproducible. The first thing they did is they stopped taking their arthritis medicine. The second thing they did was they stopped taking their blood pressure medicine. The last thing they did, after they had stretched it out to every other day, was to stop their diabetes medication. Co-payments deter people from necessary care just as often as unnecessary care. And you may think, oh, it's only a $20 co-payment. If you ain't got it, you ain't got it. And so, what's it gonna hurt if I miss a day? Or I get paid on Friday, today is Thursday, okay, so, Saturday, so I miss a couple of days. How bad could it be? So cost sharing certainly has been proven to be ineffective in containing cost. Because when you have that stroke, it's going to cost us a lot more than if we had that diabetes controlled and that blood pressure controlled. So health planning with explicit capital funding, in other words, not diverting dollars from healthcare delivery to investing in a new, fancy, whatever it is. If it's a Da Vinci robot or if it's an MRI, it's whatever the latest toy of the months that we have that we want to buy. So, because profitability reflects not efficiency or quality, it reflects avoiding those expensive patients who are not going to be able to afford to pay for their care. So profitable healthcare institutions are able to expand and modernize, while institutions that take care of less profitable patients or people, regardless of their need, are left behind. So when candidates say, you know, I support Medicare for all, let's make sure they really mean a single-payer Medicare for all. That's simple, prudent, and I believe we could do it in this country better than any other country has done it, because we have that capability. I think we have a choice. We still have people who are talking about rolling back the ACA. We have people who believe that we can regulate, improve upon the ACA. I heard them say it at the debate, we're going to make it better. I don't think we're going to get to the point that they're like the sickness funds in Europe, or we could look at a single-payer Medicare for all. I think that that's the answer. I'd like to leave some time for us to talk about it, and I'm going to leave with a picture of my mentor, a guy by the name of Quentin Young, who I practiced with for a dozen years, who taught me a whole lot. But he said to me, you know, Claudia, it's real simple. What we want is a plan that gives us everybody in and leaves nobody out. And I'll stop there. Thank you. I'd be happy to take questions.
And
Yes, ma'am.
I have a microphone here, which we can pass around.
Hi, thank you so much for your talk. I was leafleting for this talk on Saturday at the farmers market, and a couple comments came up. One was, well, I have a Medicare Advantage plan, and I like that, and so I'm not for Medicare for all because I'd lose my advantage. And another one was a guy who said, well, I really like my Medicare, but I don't want everybody to have it because then they'll mess it up.
That's sort of like I got mine.
He was in the
you
back
get
of
yours.
the boat.
Right. But let me talk about the Medicare Advantage plan, because now 34% of Medicare recipients have Medicare Advantage, which is a Medicare managed care product. And what a lot of people don't realize is when they have that they've actually lost, you know, that car. And so actually we've looked at that, and they said people who are over 70, they cling to that red, white, and blue card because they didn't grow up with that managed care. But people who are less than that, younger than that, they're happy to roll it. They've been in managed care for several years now, and they're comfortable with it, and they go to it. What we find is that people with Medicare Advantage plans very consistently, when they develop a serious problem, they need a joint replacement, they get cancer, they opt out of the Medicare Advantage plan to get a choice in terms of where they go and what treatment they get. The administrative costs of the Medicare Advantage plans are very high. So someone who has that plan and likes it hasn't had to use it. So, you know, so let me just say this. How many people are insured? Okay. So, how many people, because almost everybody's insured, how many people know if you were to go outside and get smacked by a bus, how many physical therapy appointments are you entitled to under your plan? Anyone know? There you go. It could be a dollar amount, it could be 2 or 3 visits. So, the next question is, if you have the misfortune of having a family member get cancer or leukemia, does your plan allow you to go where you think you will get the best care? Does it allow you to use experimental medications? You know, so we think that we have good insurance until we have to use it. The Advantage plans are really quite pernicious, and the reason they're pernicious is because they target able-bodied seniors, and they get paid a lot. They spend consistently less per member for those Advantage members than traditional Medicare does. And traditional Medicare is becoming subject to adverse selection because people who don't really have a lot of problems go into the Advantage plans because they're cheaper, and the companies pocket the rest while traditional Medicare winds up with the higher plan. So it really have to have a bigger view of the world before we say that Advantage, because we are consistently seeing people rolling out of Advantage plans, getting high-priced care, and then if they're better, rolling back into the plan. So it's a cost savings, but it's at a high cost for everybody else. Yes, sir.
Yeah, I've got two questions. One is political, and the other one is structural, the cost structure. In terms of the political question, Medicare for All is very dangerous in the sense that a lot of people will not support it, as opposed to a public option. And I think most of us think a public option and the risk that the reason that people don't like it.
I'm going to put that slide back in because I had a thing about public option.
Well, the public option, I think most people against Medicare for All think the public option is bad because within 4 or 5 years, everybody would be in Medicare because they would like it. But I think it's politically more palatable than Medicare for All right away. So that's my comment. The second question has to do with cost structure. I think every hospital in the United States will tell you, or at least they say publicly, we cannot live with the cost, with the prices that Medicare pays. Now, the question I have is that because they charge too much or because it's really true? You know, there's a comment, just an anecdote. We were in Italy a couple months ago, and we walked by this place on the way to our hotel like every day. And one day I saw a lot of ambulances out front. I said, I wonder what's going on with that place. And so I walk in, and I realized that the ambulance was parked there. And I said, I wonder if that's a hospital. And I walk around the little thing, and this is a glass building, looked like an office building. And I said, my God, it was a hospital. I started reading the sign. I had no idea. In the United States, you can never walk by a hospital and not know it's a hospital. So is the structure, the cost structure, real, not real, made up, high cost? How do you deal with that problem?
Well, first of all, they don't even have any idea what they'd be paid under Medicare for All, because it doesn't say in any of the bills what the payment structure would be, payment rate would be. So that's a contrived thing. That's the American fear of change. But no hospital expects to be paid what their 100% of their charges. That's simply not true. I'd be curious as to hospitals that say they couldn't survive on Medicare rates, what their charity care rate is, and how many Medicaid recipients they take care of. Because if they say with the Medicare reimbursement, which is going to be higher than both of those, in the majority of hospitals in this country, the majority of the patients that they see are Medicare recipients. And without them knowing what we will pay, you know, it could be that their cost structure is high. I mean, I give the example of the University of Chicago, which is in my backyard, and their cost structure is such that they are expecting a couple of sheiks from Saudi Arabia to fly over in their private planes and pay cash, and they lose money on. They really do lose money on Medicare recipients. Most hospitals live for Medicare. Mainly for-profit hospitals have a structure that doesn't tolerate that. So I'd be really interested in what they think that their cost structure is. I find most of this pushback resistance to change, which we have a lot of. The public option is very problematic because it does not get us the savings in administrative costs. And I resent that Jason Hacker's PhD thesis becomes a topic of possible why we could insure the rest of the country with it, because it's not really thought out to the nth degree in terms of how it would be administered and how we would do it, and whether we could actually achieve that. I'll remind you that we were able to enroll everyone in Medicare in the United States in less than 11 months, and it was because they just said everybody born after this date will henceforth be enrolled. And we didn't have big mainframe computers. We didn't have smartphones. Because if you don't think that the federal government knows where you are and who you are by now, you haven't been paying attention. But the argument, I have to begin to talk about this thing about the hospitals saying they couldn't survive on their Medicare rates when the majority of them do quite well with their Medicare rates. I think we're going to have more discussion about that. There's nothing to substantiate what they're saying. There really isn't. Yes, sir.
My question is, what will happen to the income of medical personnel? Right now, American doctors make about twice what the other industrialized countries, what doctors do in other industrialized countries. Nurses make about 30% more. I assume hospital administrators are way up there. What will happen to the incomes of medical personnel?
That's a really important question. One of the things is that people will take home more of what they make. It's true that people in America, in the United States, make more than doctors in other countries, but we take home less. We take home less because we have to pay malpractice insurance. We take home less because our overhead is higher, because we have hundreds of different insurance companies, and they each bill differently. And as a result of that, for hospitals, doctors, anyone who's in that enterprise, the billing structure. I visited, with Senator Sanders, as a matter of fact, we visited a hospital in General Hospital, Toronto General Hospital, which had 500 beds. And we visited their billing office. Want to guess how many people work in the billing office? 1.5. One person who half of their job is something else. So that's a huge administrative cost that goes away. So I remember when I was in private practice as an internist, we took home about 35 cents out of the dollar because we had to pay billing clerks, we had to pay to argue with the insurance company. We didn't get paid for half of the work we done or a third of the work because it was contested. We had to resubmit and resubmit and resubmit. So actually what the reality is that the doctors don't make out half bad. I actually don't know the answer to the question about the nurses, but the doctors don't make out half bad because their overhead goes down, and so even though their salary might be less, they take home a greater percentage of what they make. There's something about knowing you're going to be paid for everyone you take care of that changes the equation, that makes it very different. Yes, ma'am.
I was wondering if you can talk a little bit more about like how you could actually get this done, because I think you're talking to probably people who are somewhat at least amenable to the idea of Medicare for all, but in terms of like the national landscape and like the way the ACA turned out the way it was because of a ton of compromises, because of all the political play that had to go on, like how like what do we need to do?
Right. So there is no legislation in this country, and there's a gentleman down front who's been trying, David, who's been trying to get attention. Well, but there is no legislation that occurs in this country without compromise. That is reality. I'm a realist. But what I will say is that this is like many social justice issues that we have dealt with in our country. Whether we talk about the women's right to vote, whether we talk about civil rights legislation, whether we talk about, we don't even want to revisit the war in Vietnam. But what happens is there is a groundswell, there is a grassroots movement that has to happen. And so how do we get our legislators? The one thing legislators, very important to them, is getting reelected. It's like the most important thing. And so when someone calls their legislator up and says, do you support improve Medicare for all? And if not, why not? So, okay, they got a phone call. They get 10 phone calls in the same day. They're like, uh-oh, something's going on. If someone goes to visit their legislator, whether you visit them in Washington or you visit them at home, they take notice. If 3 or 4 or 5 people go to visit them in their office, let alone 10 people, they're in a panic because that represents a movement. People aren't activated. We vote, but it's sometimes a mindless activity. And I watched the past president of PNHP turn one of the senators, she's from Nashville, Tennessee, and she showed up as senator every time he was in town, every time he spoke, she showed up in the front row and asked him, do you support Medicare for all? What we're talking about, do you support Medicare for all? And she did it again and again and again. And she turned a no vote to a yes vote. He couldn't stand it. It created public pressure. What people have to do, anyone who's in medicine, especially when you have those initials after your name, MD, RN, that makes an impression on legislators because they recognize that you are a sphere of influence within your community. And we have to start to talk to the people who are supposed to be representing us about what we think is the right thing. We may not agree, but what we have to do is educate ourselves and become activated in the process. Because I'm going to tell you something. I've been practicing for a while, and I remember in the 90s when the MBAs came in and they were going to make healthcare more efficient. And a lot of us put our heads in the sand and said, I just want to take care of patients. You guys go ahead and do that. And they came up with these cockamamie schemes which deny people care and result in death. And it's all of a sudden we look up and say, whoa, what happened to medicine? What happened to primary care physicians? What happened, why are we suddenly the bad guys? Because we allowed someone else to direct the work that we thought was most important. Taking care of patients is not like making widgets. So I'm well aware that, I'm talking to a bunch of folks who are really immersed in this, and what I'm telling you is I'm talking to you to make you aware of the statistics. Everything I presented to you has peer-reviewed, factual data to substantiate it. We have to provide you with the sources. You have to educate the patients and your colleagues. I have no problem with the residents when I'm making on rounds asking me, how do you feel about this? Because I think they should. Because they're going to be practicing in the mess we leave for them. And we have to work to make a change and talk about it. We talk in this country a lot. If you see something, say something. Every day, we're seeing the results of poor planning with regard to health care in this country.
May I clarify something on Medicare Advantage?
Sure.
When you sign up for a Medicare Advantage plan and you're in that Advantage plan for a couple years and you get that serious illness you talked about, yes, you can leave that Advantage plan, but you are not going to get a Medicare supplement because you have to health qualify for that Medicare supplement. And therefore, you're left with just traditional Medicare, which means that's an unlimited liability. So people that think they can go into those Advantage plans healthy, get out of them and get a Medicare supplement when they're not healthy, they're whistling up the wrong tree because it's not going to happen.
It's a problem, but we see a lot of it. We see a lot of it.
So that was a wonderful presentation.
You support single payer and says I can't vote for
Well, that gets into the whole politics of it. I don't endorse any particular candidate, but I will say that sitting on our hands put us in the mess we're in now. And if they think it's bad, I think that a second term might be more than painful. I can't go further than that. Yes, sir.
So that was a wonderful presentation. But I guess the concern I have goes to the question that one of the students asked about, is it too high a mountain to climb? And the reason I ask that is there's simple things that we can do now. So for example, we can't even get Congress to agree to allow Medicare to negotiate drug prices.
Yeah.
Okay.
How about that?
You come from a county hospital, and for those of us that are old enough to remember Hill Burton,
Yeah.
it said that if you receive federal Medicare dollars, that 10% of your income had to be devoted to indigent care. I would be willing to bet that the private hospitals around Cook County are not fulfilling their Hill Burton
Oh, you're right
obligation.
about that.
So, it's like if maybe the focus should be going after these things that we know that are probably a little bit closer to get before, and making people aware of these kinds of issues before we go to tackle such a.
I appreciate where you're coming from. You're talking about incrementalism. I will tell you that Lyndon Johnson thought that Medicaid and Medicare were the first steps toward universal health care, and that there's a wonderful book called The Heart of Power, I think it's called, where they talk about going from Roosevelt to every president has tried, and Obama was the only one who was able to drag it across the finish line. But I have to go to my upbringing and say that my father was a labor union organizer, and he taught me that you never ever compromise until you get to the table and you're eye to eye with the person you're negotiating with. We're not at the table. And I am reluctant to compromise now. Those may be simple solutions we can get, but we've been, incrementally our way into a really bad spot. And, we talk about drug prices. I had a woman last night suggest, why don't we just try to fix Medicare Part D? Medicare Part D was abysmal. The idea we told the Secretary of HHS, you can't negotiate prices. So I just don't have confidence that compromise on this, trying to go a part of the way now and see if we can't get there later. I feel like we need to hold people accountable. We may not get there at the end of the day, but if we don't charge and fight for that, we are not going to get close. My kids tease me because they've heard these lectures for years. They're both in their 30s. They said, yeah, single payer was off the table and on the floor and not even ever in the room. So we're struggling with that, and I just feel like we really have to rise up and say something different. And I think I'm running out of time. Can I do one more question? Okay.
I'll make this quick. I'm curious why there isn't more of a push towards the Bismarck model. I'm curious why there's not more of a push towards the Bismarck model when it seems like it might be met with less resistance culturally. Maybe I'm wrong about that. But
Yeah, well, so the Bismarck model, again, I said because it's so highly regulated, and the notion of telling insurance companies that they can't deny anyone and that they all have to offer the same benefits, and that if one makes more than everybody else, they have to share. Those sort of regulations kind of like, you're not going to get to sit at the Chamber of Commerce table with that. They're just not. It's not going to go with their business model because the insurance industry is highly competitive. It's all about competing, and they would say you're making them fight with both hands tied behind their back. I've sat in Chamber of Commerce meetings, by the way, and yeah, they aren't talking about that, and we haven't forced them to have that conversation either. Yes, sir.
Two-part question. I don't hear a direct correlation between the Medicare that we have now and the proposed Medicare for all. I hear, I sense it is not very clear that the new Medicare plan would eliminate these Part C and D programs.
Yeah, it would, because why we say improve Medicare, because like I said, so the Medicare, traditional Medicare is built on the premise that you had to have financial skin in the game, and actually requiring people to have, purchase supplemental insurance instead of covering everything is a huge problem. And not covering drugs is a huge problem. And breaking it out into separate parts, A, B, and D is a huge problem. And I'll say real quick, so I'm coming up on 3 years when I lost my husband to leukemia, and he had, it was a great thing. We were married 37 years. We had a really wonderful go at it, and have 2 wonderful children. But my husband had 8 hospitalizations in the 10 months that he was sick. And his first hospitalization, I have good insurance, remember, I'm a chief medical officer for one of the largest health systems in the country. And the first hospitalization was 31 days long, and his bill was $200,000. His second hospitalization was 28 days long, and the bill was $180,000. The third hospitalization was 23 days long, and the bill was $150,000. While we're going the right direction there is no one who has that copayment. Christopher Reeves fell off a horse and broke his neck, and he exhausted his insurance within the first few years. Robin Williams paid all of his health benefits for the last 5 years he was alive. No one makes enough money to pay for that care. That risk should be shared among society, and that's what we talk about improved Medicare for all. There cannot be deductibles. There cannot be copayment. There should not be supplemental. The insurance industry cannot be involved in this. I have no objection to the insurance industry making money for house and annuities, for fire protection, etc. But we cannot profit on the backs of the sick and infirmed. That's it.
Thank you all for coming. A reminder that if you're interested in working in this issue, there's an email sign-up list on the outside. And once again, thank you, Dr. Fagan.